Welcome to the Medical Home webinar series. Today's webinar is the fourth webinar in this series. This webinar will be presented by Dr. Joann, a clinical geneticist at McKusick-Nathans Institute of Genetic Medicine at Johns Hopkins University, Maria Isabel Frangenberg, a diversity and inclusion consultant, Family Voices National, and Helen, a consultant at Dow Consulting Services. Before we begin, a few announcements. This webinar is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under Genetic Services Project Grant to Health Research Inc., NYMAC. This activity has been approved for AMA PRA Category 1 credit. There is reciprocity credit for allied health professionals, nurses, physician assistants, and nurse practitioners. The required CME accreditation is included in the slides and handouts, which can be found in the control panel on your screen. Instructions on how to obtain a CME certificate of credit is also included in the attached handout. This live webinar will take approximately 1 hour and will be recorded. The recording will be available at a later date. As soon as the webinar concludes, you will be asked to complete an evaluation survey. Please take a few minutes to provide your feedback. Your input will help us in planning future activities. Participants claiming CME credit, please use the How to Obtain CME Credit instruction handout to complete your evaluation and claim the CME credit. All other participants, please complete the evaluation survey that follows after the webinar. There are no conflict of interest disclosures or off-label discussion to announce. At this point, we would like to acknowledge our colleagues. We thank HRSA for their support for this activity, and we thank all our speakers and participants of the Medical Home webinar series for their contribution and participation in this series. Should you choose to ask questions or have comment to share, please use the question box in the webinar tool panel to submit your questions and or comments. We will cover as many questions as the time permits, and responses to the remaining ones will be emailed later. We encourage you to think of some real-life experiences to share regarding this webinar. On that note, we are pleased to invite our speakers to present today's webinar on Cultural Humility, Healthcare for All. We'll begin with Dr. Joann Bodurtha. Thank you for your time.
Good morning or good afternoon, wherever you are. I'm delighted to be here with Maria Isabel, Helen, and Kunal. The slide next is about our objectives for today. Why are we talking about cultural humility? Again, you can read these, but I want to provide a context and framework and ask you to be thinking right now of clinical outcomes, whether you come at this as a patient or advocate or provider, that might be improved with enhanced attention to cultural factors that impact the medical home, care coordination, and reduce health disparities by looking at healthcare for all. Today, Maria Isabel and Helen will be speaking of examples of strategies for integrating cultural humility in practice, but we're going to start with a brief outline and some definitions. Next slide. They will present some stories and strategies across linguistic and language and cultural diversity, again, with our broad thinking about enhancing care coordination and genetic services, and then moving forward really across this area as our country and population become increasingly diverse. So we're going to start with a brief video about empathy. So be patient a minute as we work on our technologies. Then we will provide some additional physician and provider perspective. Again, talk about integration of these within the clinical setting. I'll have observed, I hope we get some comments and questions, and really where cultural humility factors contribute to our interaction. So Kunal, can you roll our video on empathy? Sound? I find that video very powerful. I know it's really never possible to totally stand in another's shoes, but it does make me think about empathy as much as possible and keeping eyes and ears and hearts open in all situations. I'm going to move to the next slide, Kunal. So in terms of those providers on the phone as well as recipients of care, have you ever observed a provider bypassing in-depth questioning, miscalculating the competence of a patient or you, limiting your questioning, overlooking your concerns, not recognizing the potential cultural relevance of symptoms, using demographic characteristics to infer causality, or miscalculating patient decision-making capacity? All of these may represent implicit biases. Next slide. Oh, sorry, you're on it. So cultural awareness is generally taken to mean understanding of how culture informs our beliefs, values, behaviors, and basic assumptions. You'll hear more about cultural brokering as a bridge and link or mediation between persons of different cultural backgrounds. Competence is a term that's still used a lot, but it's some critique because it may represent as if you somehow arrive. You've learned that people may have this preference if they're of this ethnic background or nationality, and obviously we all want to be appreciated as individuals as well as part of different cultures, and we all have a wide variety of cultural identities. Culturally safe environments are ones that do not deny diverse identities and needs. Cultural sensitivity is that skill that allows us learning about other cultures and differences, and we appreciate that the folks on this webinar are paying attention to these issues. I'm going to go ahead and read a definition of cultural humility now, and then Maria Isabel will take over with a concrete example and story. So cultural humility, what we're talking about today, teaches that healthcare providers optimally allow each patient to inform the provider as to the important aspects of the patient's personal culture, so that the healthcare provider and patient form a mutually respectful and humble partnership working toward the patient's better health. Maria Isabel?
Thank you, Joanne. It's wonderful to be here. So with that, I would like to bring you a story of a family. And this is a story that a genetic counselor shared with me. So let me tell you a little bit about the family. These are new immigrants from Sudan. They're Muslim, and they had limited English proficiency, so they required an interpreter for every interaction. A little bit about their personalities. The wife was not very vocal. This is what the genetic counselor observed. And really, any time that there was an interaction, she would defer to her husband to answer questions. As far as their baby and why they came into the genetic counselor's office, the pediatrician noticed the baby's very small size for the age, so they suspected that there were some fairly important issues going on. The baby was failing to thrive. And the baby was hospitalized the same day that he was seen by the pediatrician. 2 weeks later, in comes the genetic counselor, who is the person who is telling us the story. Slide, please. Can we go to the, thank you. So the genetic counselor, she was wondering, she had gotten some training already, and when she met the family, she knew that she needed to engage one of the Sudanese interpreters to help her interact with this family. So the genetic counselor expected that the interpreter would follow the strict model, requiring that the interpreter would only interpret what the counselor said, as well as the responses from the family. I need to give you the background that this interpreter was one of only 2 in the community. So that will bring us to a couple of realizations later on. But what the interpreter did was a little bit different, and it surprised the counselor a bit. So when the counselor was trying to get some information from mom, the mom started crying. She was worried. So the interpreter immediately intervened to console the mom. And it really didn't allow for the mom to respond to the counselor's question. So immediately that flow of information and relationship building was interrupted. Then as the meeting went on, the counselor began explaining the situation to the family, of course, via the interpreter. And at one point, the interpreter interjected and said, well, you know what? They're very young. I don't think they'll understand that, and did not interpret. So the counselor felt really that she was not being able to develop a relationship with the family. So it never really felt like she had an understanding of what the family was feeling. And so when we look at the slide here, that when we see that the Sudanese interpreter had an already seemingly close relationship with the family from previous interaction, the counselor expressed feeling left out. Actually, she had come in at a later date, and they knew each other well, and it didn't feel very comfortable. So I have here, but I am so much more, the interpreter as coming in, the expectation is very different from what she really became. And so this is where I would like to turn it into Helen, where she's going to talk to us about cultural brokering. When she's going to talk to us about cultural brokering from a trained perspective and without surprises. So here's to Helen.
Thank you. Good afternoon. Good morning, everyone. Thank you, Maria. Yes, I think that one of the things that is very important for us, for providers, whether you're a primary care provider, nurse, a social worker, it's also for the front desk staff to be have a good understanding what the differences are between cultural brokering and interpretation services. And cultural humility really could not represent cultural brokering in a better way than it does, because it is all about patients' personal cultural understanding and providers feeling comfortable with that. Next, please. So what is the goal of cultural brokering? What it is that we're trying to learn, and when it comes to different strategies that can be incorporated into cultural brokering. And the strategies have to be that produce results and eliminate misunderstandings between providers, families, and the patients. Next. So the objectives of cultural brokering is, as a cultural broker, we want to be able to understand and respond effectively to diverse belief systems related to healthcare and well-being, and also social factors that the families or the patient might be experiencing. We also want to learn as cultural brokers how to create and implement cultural brokering strategies that will minimize through communication barriers or minimize any errors in communication between families and providers. And the third objective is to cultural brokers to use best practices to sustain effective cultural brokering services or programs in their practice. Next, please. So cultural brokering, what is cultural brokering? This is really the action of the cultural broker, and the explanation that we have here is the act of bridging, linking, or mediating between groups or persons of different cultural backgrounds for the purpose of reducing conflict and producing change. Next, please. So a cultural broker. The cultural broker is someone that the families and the providers identify as the go-between person, one who advocates on behalf of another individual or group. Next, please. One thing that I want to say in regards to cultural broker is that this person becomes sort of the point person, the key person that a family or the patient feel comfortable and they identify with as well. So a cultural broker doesn't just meet the linguistic needs of the patients, but also meets the cultural needs of the patients or families. So historically, it's important to understand, to know and understand the difference, yet some similarities between cultural broker and an interpreter. So the historical review of the cultural brokers are not the same as interpreters. Also facilitating both languages if there are two languages involved. It is almost an essential factor, and they can act as language interpreters as well. The more important part of the role is that they can interpret the culture for one of both groups. And this is very important to know the difference, because most of us, I would say, that are very familiarized and have used interpreting our practices to help us communicate with the families and patients that we serve. But an interpret, there is a certification, there is a training process to go through where it's very specific. They interpret exactly the information that they need to deliver or to interpret to the families. A cultural broker, in a sense, is that what we have seen when we implement the cultural broker as a practice, that cultural broker really can be an interpret, but it has a broader knowledge, broader set of skills when it comes to the patient's personal culture. The cultural broker can identify him or herself with the patient when it comes to not only the language, but also the cultural background. Next. How has cultural brokering interventions worked in some of the primary care settings? Some of the cultural brokering programs can be integrated in many different ways. It really varies from practice to practice, from organization to organization. It really depends on what the organization internal structure is, how many providers, how many non-clinical staff are available, and also the composition of your staff. So keep this in mind that if you're thinking about training a staff or identifying individuals at your organization or practice, that you have to be able to train the individuals in different ways. And we will get into that later on in more detail. A cultural broker really serves as a liaison. So serve as a communicator and liaison between the patient and providers. And this is very important because as the cultural broker begins to work with the patient, there will be a very close relationship that will develop between the patient and the cultural broker. In many occasions that we have seen is that when the patient comes to the next office visit, instead of asking for the provider, they immediately, the first thing they do, they will ask for the cultural broker. And really, this is more for practices that they have formalized a cultural broker program. A cultural broker is also a cultural guide. Cultural brokers can assist in developing educational materials that will help patients to learn more about the healthcare settings in the healthcare system. And the way we have seen cultural brokers work in this way, collaborating with organizations, is that when organizations are developing different educational materials, or they're starting a class, for example, in diabetes, the cultural brokers become very essential in the process of developing these educational materials, because they really help out with the nuances. For example, how will a specific community, let's say, a Central America community, will identify more with the advertised educational class that the practice is giving. And it can go from the way that it's being promoted, it can go from the way that it's being marketed, the way also what colors scheme are they using on the flyers, or are they using the promotional materials to attract a specific population. And all these nuances are really, really important, do make an impact and a difference when it comes to serving a specific ethnic population. And the cultural brokers will be essential in helping the organization to identify the nuances that should be addressed at that moment. Next. Cultural broker is also a mediator. Cultural broker can, bridge gaps of trust and communication between community and the healthcare system. In our case, organization and practices. Sometimes there might be some misunderstandings between a provider and a family or family member. And the misunderstanding might be very simple. It might be that because the provider doesn't really understand the cultural background of that family, that there might be a misunderstanding. That could be a very simple thing, or can escalate. A very quick example that I can give you is there was a cultural broker that served as a mediator because the provider was making a recommendation to a mother who had a young lady who had a severe developmental disability. In the way that the provider made the suggestion of start seeking for residential placement for her daughter, it was not captured very well by the mother. And, in summary, the way the mother understood was the provider was saying, you're not a good mother. You cannot care for your daughter. Therefore, you should be placing your daughter in a residential facility. And obviously, that escalated to the point that a cultural broker needed to be identified to serve as a mediator to explain the mother what the provider meant and how the provider meant it, and also work with the provider to understand that for these specific ethnic groups, even mentioning that they need to put their loved one in an institution or a residential facility is a definitely no. So that's one of the ways that a cultural broker can be used as a mediator. So I wanted to share that example with all of you. And also, a cultural broker is a catalyst for change. They help organizations to build capacity from within to adapt to the changing needs of the community that they serve. The cultural broker can serve many different roles, as we have seen so far, as a mediator, as an agent for change, where they become involved in the community. They become identifying some specific needs that some ethnic groups might have that the organization might not be aware of. And that is why it is important that when the practices identify a cultural broker, the presence will be someone from the same community they're trying to target. Next. So this is sort of a model for, cultural brokers. But a lot of the practices nowadays, a lot of organizations who use health educators or community health educators. And a lot of these individuals that are in the community are truly serving as cultural brokers. One of the things that is very important is that if an organization decides to identify individuals that they are not just being trained to provide to health promotion or health education or interpretation services, but they also can be trained in how to become effective cultural brokers because they already have these natural skills that they can bring and enhance the cultural competency services that the practice is providing. So you have sort of a holistic approach in a way. So for patients and families, what it means to have an organization that really cares about the personal cultural, composition or cultural background is that it really increases the satisfaction of services. So they can feel comfortable in going to the organization, going to the practice to access the services that they need, because they will feel that if I go to this X organization or this X practice, I know I'll find someone that speaks my language, but at the same time understands my cultural needs or my system of, we share the same system of values or beliefs. For the organization, it really creates organization about cultural humility among healthcare providers. This is very important because the cultural brokers, the way have worked for some practices is not just working directly with the families and the patients, but also working with the providers. And we talk about doctors, nurses, social workers, case managers, so everyone that is part of the practice, so they work with them and they raise awareness about cultural humility, how key they have to be about the different cultural needs that the families might bring with them and how they need to address them and how to, when they are interacting with the patients or the families, what is really the proper way of asking questions. So it really goes into more details, and it improves the awareness of the organization being ready in order to meet those demands. And also self-time liaisons between patients, families, and providers. It creates in the community a sense of, creates and identifies cultural competence services that organization, that your practice truly is invested in serving patients that come from different cultural backgrounds and are very sensitive, not only to the healthcare needs, but to the cultural needs and linguistic needs as well. Next. So some of the core principles of a cultural broker, as you go about identifying these individuals, you might already have these individuals, you might just not know. And a lot of these individuals at your organization might already be serving a role as a cultural broker, even ourselves, with our families, even ourselves with our, when those that have children and we have to go to school and advocate for our children or mediate for our children with the school system, we are cultural brokers, because culture, we have to also understand that it's not just based on ethnicity. That we have individuals with developmental disability, hard of hearing, with vision impairment. So these are specific communities that have their own culture that we also need to be sensitive to. The individual should be, honored, respect, have a transparency, be respectful of the beliefs that the families have. Sometimes, they might not agree, but their role as a broker is not to to agree or not. It's just to really help the organization, the providers, understand the family's point of view, what their feelings are, and why do they do certain things the way they do it if it's related back to the cultural background. It is family-driven. Cultural broking is family-driven, so we are not just providing cultural broking service for one individual. Once we are engaged with the family member, we engage with the entire family and really with the entire community. Serve as a mediator, be non-judgmental. Cultural brokers, we are not there to judge people what their beliefs are. We're there to serve. And also a strict confidentiality. Families need to feel that whatever they are sharing with a cultural broker, it is confidential, and this is whatever they share with them is not going to be a topic of conversation in the office among the colleagues. To unite and to understand is to work the organization to really build a much stronger tie with their community that they serve. And service delivery accessibility, where families, again, community members feel that that particular organization, that particular practice truly has a holistic approach about their individual and family needs, and as well as the community. Next. So some of the barriers that organizations that have experienced and will continue to experience is really when the organization has not really have probably full understanding what the difference is between interpret services, cultural competency, and cultural brokering, and really try to invest and make a commitment to cultural competency in the mission. So for an organization to make that commitment, cultural humility, cultural competency should be part of the mission, should be embedded in the policies, and leadership has to buy into why it is important. Because cultural humility or cultural competence is really not something that it needs to be done or it's the right thing to do anymore. It is a must. It's a necessary in order to provide high quality of services. Next. And obviously, many of our organizations and practices lack resources. They have limited funding. A lot of organizations have expressed to me saying, well, it's all great, we want to do this, but we don't have the funding to pay for this. And some of the ways that organizations that they have gotten created, they have sort of do a self-assessment around, the diversity of employees that they have, what cultural backgrounds they are, what languages they speak, and it's more like an organic system of cultural brokering that we can say. It's really more organic. It comes from the organization. These are staff that already know many of the families, many of the patients or clients, and vice versa. The clients, the families might feel comfortable with them as well. So, it is understandable that there will be lack of resources, but we always suggest that look into what you already have. Look at your internal assets, capitalize on your assets that you already have on part of your organization. Next. And in summary, by practices, what are some of the practices that have implemented cultural brokering or cultural humility? What are some of the lessons learned that they have shared with us is understand the developing of cultural linguistic competency. It's really an ongoing process, as we all know. It's not just about going to trainings. It is something that it has to be practiced on a daily basis, and it can be done at small scale or larger scale. It's based on your internal structure. Some of the strategies is that practice cultural humility, and sometimes cultural humility, cultural competency, cultural brokering. These are new terms for a lot of providers. So when an organization makes a commitment to a provider training, so everybody can start getting familiarized with that. Institutionalize your commitment to cultural and linguistic. Again, make it part of your policies, make it part of your mission as an organization that you're making a commitment to really, serving patients from different ethnic backgrounds in order to meet their needs. And build providing a staff capacity to recruiting the right people and training them as well, and providing ongoing education, ongoing reminders that we are an organization that truly serve people that come from different cultural backgrounds. And I think that's what Maria started saying with her story about, this family and how they, at first the organization, so they were providing some of the most effective cultural competency services, and then the interpreter got involved in some of the communication that happened among that. So I know that Maria has the second part of the story where she will, be able to expand more of what really happened with the family.
Thank you, Helen. That was wonderful. And with that in mind, let's pick up back with our family and the genetic counselor. If you remember, we left her off feeling rather alienated from the family that she was trying to help. And as you might guess by now, one of the reasons was, you're surprised you have a cultural broker instead of an interpreter. And as Helen mentioned, there's quite a difference between the two. So trained cultural brokers are an incredibly important part of the team, and they do bring all these invaluable resources that Helen shared with us to the table when agreed upon in advance. This is a very, very important piece. They enhance the ability of the medical provider to form tighter bonds with the patient and the family, or with the consumer and the family. And the key here is, again, advanced knowledge of what everyone's getting. Slide, please. So let's talk about communication, because as we can see, surprises in the room are not, it's really, when the family's there, that's really not the greatest place to have those. So communication between the interpreter and the provider prior to the appointment is essential. Some providers know their interpreters well. They have had several interactions before, and they kind of get each other's rhythm. In a lot of cases, this is not the case, just because either the population is small and this is a new interpreter, or whatever the reason might be. So please remember, communication is essential. So to ensure that the interpreter or cultural broker become a helpful addition to the team, the first thing to be done is for the provider to take 5 minutes before the appointment and without the patient present to clarify expectations. For example, ask about style. Here again, style would be, are you an interpreter, a strict interpreter who says what we talked about before, you're only going to interpret exactly what I said, or are you going to interpret, are you going to paraphrase? Set your expectations when it comes to that. If you're thinking that, well, I really want to hear what the family's saying, just talk about this in advance. So you'll notice also that interpreters of less represented languages tend to feel obligated to advocate for the patient. One of the reasons for this is present in our story, which is that this interpreter, the Sudanese interpreter, was one of 2 in the community. So usually they form part of that community and they see the families in other areas. So besides just that appointment, they might have seen each other at church before or at a community dinner. They may know each other. There might be more of an advocate role already implied in that relationship before you got into to meet them. So, if there is a brokering model already implied, and that is what you're looking for, be sure that you set some expectations in advance and some ground rules. For example, when the family asks questions, then you might want to, would you ask the interpreter to first interpret the question and ask the interpreter to attempt to answer it first for the family? Or when the interpreter has the feeling, quote unquote, that the family is not understanding as it happened in our story, you might want to ask the interpreter to let you know that they're concerned that the family is not understanding, so that you, the provider, decides what to ask next and how to pose the question differently, rather than allowing the interpreter to kind of paraphrase what you're saying. Now remember, some people say, oh yeah, I can let them paraphrase. I know them, I like them. So if this is something that you decide to do, remember, the interpreter is there because you don't know the language. So you probably won't know what the interpreter is saying when they're paraphrasing what you said. And so that kind of puts you in a bind of not really knowing if what they said is accurate to what you were meaning. So try to keep a close eye and a very open channel of communication with the interpreter prior to that, just to make sure, remember, the family here is at the center. But just to make sure that the family is getting the message that you intend for them to get, but also so that your message is being adjusted appropriately to the family's understanding with your knowledge. Just communicate. Communicate. That is one of the most important pieces in advance. We can go to the next slide, please. As some of you may already know, there are national class standards which were developed by the Office of Minority Health, and I have the website right there for you. This in itself would be an entire webinar. But I wanted to, number one, tell you what are the national class standards for those of you who don't know or are not very familiar with them. I'm going to read you this straight from the website. The national standards for cultural and linguistically appropriate services in health and healthcare are intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services. Adoption of these standards will help advance better health and healthcare in the United States. So this is where all the availability of interpreters is coming from, and of course making sure that the families are able to access all these resources free of charge to them. Again, please go to the website for more specific explanation and for the standards themselves. Or you can ask me during the question and answer question if you have specific questions about that. Please feel free to ask me, and I'll be happy to answer. Next slide, please. So you are hope. I usually like to end on this note. When people talk to me about providing services for linguistically and culturally diverse families, they often talk to me about how difficult it is and how they really want to do a good job. Providers are always keeping that in mind. They really want to keep the family first and do a good job for them, but they say it is incredibly difficult because they don't understand where they're coming from. They don't have the they don't have the ability to know if the family is really understanding. So what I ask you is to put yourself in the shoes of the family for a minute and remember that in the end of it all, for as long as it took for them to maybe 6 months to get in to see you, what you are sitting there, even if there are tears in that room, even if the news that you have to share are not the greatest news, even if they're devastating, you are still hope. And that is something that I would love for you to take with you every time you go into the room, not just with diverse patients or consumers, but with anyone, is that you are hope and treat yourself according to that. And with that, I would like to turn it over to Joann, to Dr. Bodurtha, so she can share with us her reflections as a provider.
Well, thank you both, Helen and Maria Isabel. And it's always nice to be told you walk into the room and provide sunshine and hope. I want to mention, I guess, some of my own thoughts. So first is the mature understanding that we all have biases, and those help us, walk on the streets and in our buildings and work with our family, but they can also hold us back. For those who have never done the implicit assumption test, I encourage you to go out to the link that is on this screen and go out to it periodically, because you may be surprised in terms of those things that you use as handles in getting by in the world that might benefit from reexamination. That translates to staying open to diverse experiences and people. The empathy video has details in it that I notice anew every time I watch it, around just remembering, that somebody else is going through difficult times as well. Trying to respond to things that are challenging by not just saying, oh, that's awful, but that's interesting, that's surprising. And certainly as we learn things or find, gaps in our experiences with patients, offering thanks for their new perspectives and allowing us to help individuals. In some ways, this does translate, though, in our overall theme of how do we bring cultural humility into healthcare, particularly in genetic services, is what is a clinician to do. And I found the article by Tina Chang and other leading pediatricians that was in the November 15 issue of Pediatrics very helpful. So if we go to the next slide, what they mention, again, is that if we start from the child as a provider, we, and whatever our discipline is, can certainly screen for child and family needs and address family health needs. We can think about expanding the services in the medical home and thinking about how to extend our services into communities, homes, daycares, schools, and broader. Next slide. What they advocate are clinical approaches, including, again, not making the kind of assumptions in one of my earlier slides where we discriminate on the basis of appearances or names or something like that, that we do our screening universally and work to connect families with resources in a comprehensive way. That we think about family health and pediatric encounters, and again, thinking about going forward, moving our care outside the office into the community. So again, I try to keep that image, next slide, of hope in front of me, but encourage all of us, as we sometimes do get discouraged in the area of health disparities and how we address just the enormous differences in resources that different families have and challenges that individual patients, individual families, individual communities, are to continue our self-reflection, to talk with friends, counselors, to exercise, have good health, and try to become advocates and work with advocacy groups specific to conditions or alliances, get involved in our AAP chapter and leadership activities, practice mindfulness, our faith, listen more, maybe talk less. And as one of the medical students with whom I've worked, who himself was going through major medical issues, celebrate a bad day. It is great to have the opportunity to work with such good colleagues as Helen and Maria Isabel and Kunal, and with you all on the webinar. So thank you for your empathy and listening to us and moving cultural humility out into your practices every day.
Thank you to all our speakers for an excellent presentation. These are some of the references that may be useful to everyone. Regarding the questions, as I mentioned in the beginning, we encourage you to think about real-life experiences and share a question about or your experience with integration of cultural humility in clinical practice, or also share a cultural factor that you can imagine or have seen impact improved health and well-being from the medical home perspective. So at this point, we welcome your questions and comments for the speakers. We have one comment from our participant that the national standards for culturally and linguistically appropriate services in healthcare were enhanced in April 2013. Thank you for that comment. While we wait for more questions, I was wondering if our speakers could share some of their experiences regarding what was the most challenging part, or what has been a few most challenging experiences with regard to cultural humility in the respective practices. So in a clinical setting for Dr. Bodurtha and consultancy for Helen as a parent advocate for Maria Isabel. So if you could share some thoughts on that.
I think for me, again, the idea that different levels of openness and sharing can be so different within families and across the world and cultures. So the challenges of, I'll be blunt, certain fathers having rules over everything in the family, and how to stay open not only to those cultural preferences, but include the mother and those sort of things. And again, I don't have any magic answers to that, but I would say, because of, again, being an older female in U.S. society, where we tend to view progress in equality as a good thing, that seemingly unequal or breaks or gaps in communication across different family members is one of the harder things for me.
Thanks, Joann. Maria Isabel or Helen, would you like to add to that?
Yeah, sure. This is Helen. Yeah, so I think that for me, when it comes to cultural humility and really working with the providers, it depends, again, what setting. One of the challenges that we have had in implementing cultural brokering at some early stages has been related to more hospital settings. If the hospital setting has a residency program, that has sort of its own challenges, because part of the cultural brokering is not just to identify the individuals that serve as cultural brokers, but also to educate the providers and for them to sort of open up their mind and really start thinking about cultural humility. So the challenge has been in regards to when we have spent sort of a semester, per se, training providers, and then we have a switch of residents. And then we get a new influx of residents that we have to sort of go back again and train that. Yet they're still seeing the same families that the previous residents were seeing. So I think that, with some educational facilities, hospital that have residency training, really having a more steady knowledge of cultural humility has presented a challenge. But it's, as I said before, it's not a one-time deal. It's an everyday learning experience.
Thanks, Helen. Maria Isabel?
Yes, so I think this is very interesting, because this goes to the heart of the humility piece. So, Joann, you were talking about how it is difficult to really put ourselves in the shoes of a family where really the wife and the mother doesn't have a lot of say, or at least seemingly doesn't seem to have a lot of say. When I approach healthcare providers, I find stances without the education. Now, the humility piece is understanding this is where I'm coming from, and this is just my perspective. The humility piece comes into stopping there and not going beyond into the judgment piece and saying, well, no, you need to speak with me because you need to be empowered. You need to be an empowered woman. So I think that is a difficult proposition, but one that when it's followed really enhances the family's experience and enhances access, which is I think it is the most important piece here. We really want to empower those families to access the system to help their family with special needs. So yes, absolutely. Cultural humility is at the center of this, which goes beyond competence. As Joann mentioned in the beginning of this presentation, this is not about having to know it all about every culture so that you can approach them knowing that, oh, this is how you act when someone who's Muslim enters the room, or this is how you act when a Hispanic woman enters the room. That really is kind of an impossibility to really be able to know how everybody acts in every single culture, because there's such a huge variation in single cultures. So this is more about taking a step back to our beliefs and letting the other people be.
Thanks, Maria Isabel. We have a question. How do you address differences with parents of two different cultures of care?
Extra brokering. No, I'm going to turn to Maria Isabel and Helen.
Yes, definitely. You know, I think that when you're working with more than one culture, I think that you will need, remember, cultural brokering has to be, let's say, tailored, specific, customized to the population that you're working with. If your organization serves more than one ethnic group, two or more, and if you want to implement cultural brokering, then you have to find the individuals that are from those different communities, so they can relate and interact with those clients more effectively. You know, one thing that Maria was saying is that within one population we have so many different subpopulations. So the same thing applies for cultural brokering. When you look at your practice or your organization, you have two or more population groups, then your brokering program should be able to meet those demands as well.
I agree with
Any
Helen
other thoughts?
Completely. Oh, sure, yes, I agree with Helen completely. I've heard from people in different parts of the country that have fairly new immigrant populations with which they're not familiar, and they haven't yet developed the network of cultural brokers that they need. Always ask questions. Ask questions with a sincere sentiment of getting an answer that you don't know. So it's always, I think it's always, again, humbling when someone says, you know, I don't know how you would like this. Please guide me. And that is, I think, one of the biggest bridge builders, and one that would even enable you to broker that relationship very well for yourself and for that family that you might not understand very well.
Mm-hmm.
And that gives them hope.
Yes.
Yes, absolutely.
Along those lines, one more. How do you handle the situation when the parent shares with the broker but not willing to share with the doctor?
Yes. So the question is how to deal when the parent cannot share with the provider, but feels more comfortable sharing with the broker. Correct?
No, it's the other way. So what if the parent wants to share with the broker but not with the doctor?
Right, share with the broker but not with the doctor. Yes, so I think that, you know, that we have seen that. It really happens because if the parent, begins working with the cultural broker, that relationship, in a way, becomes to be a very personal relationship between the parent and the cultural broker. So the parent will identify him or herself more with the cultural broker because of many different reasons. One is because of the language. Two is because they share the same system of beliefs, the same cultural background, the same type of food. And believe it or not, small things like this, like the food, really makes a big difference. So yes, there will be a natural connection between the cultural broker and the parent, more than with the doctor. So how do we deal with that? That's where the provider education comes into place. And one of the things that we did learn was that as we are educating the providers about cultural brokering, about the family's cultural background, we also learned that we needed to educate parents, in this case, about the physician's culture, because they have their own culture as well. We work with families understanding, that the provider might talk on these terms, the provider might have this, presentation. In a lot of times, the provider was not even aware that they will come in across as very cold, very direct, very short with the parents. So we had to do sort of a two-way education when it came to cultural education. We needed to work with the parents as well. So we did have a situation like that where it was more, the cultural broker getting the information, but it came time for the provider really didn't understand. But it's a process that needs to be worked on. That the cultural broker, it's not a case manager per se. Even case managers will be those mediators, that link between the provider and so the cultural broker has that role. That if she thinks that the parent's coming more than the provider's not getting so much information, is that she will facilitate. So there is also another role of the cultural broker as a facilitator between the parent and the provider. But that's the way we have been able to bridge that gap that we have definitely experienced as well, where we put the cultural broker in the middle, we talk and we ask questions, and then we educate both about their own cultural background and the system beliefs that they have. And it's a process that takes time, so it's not going to happen overnight, but it has to be consistent.
Thank you, Helen, for that insight. I want to be respectful of everyone's time and once again take this opportunity to thank all of our speakers and our attendees. Thank you for attending today's webinar. Please refer to the attached handouts on how to obtain the CME credit. We have also attached the slides from today's presentation and information about the CME guidelines. Should you have more information, please feel free to contact us. And a quick reminder to complete the evaluation form after this webinar. Please note that you have until May 23rd to claim the CME credit. On that note, I would once again like to thank everyone for participating in today's webinar. Thanks and have a great day.